In this episode of Medicine Across a Lifetime, I want to begin with a question that may feel uncomfortable. What if the most dangerous condition affecting our older patients is not cardiovascular disease, not diabetes, not even dementia, but loneliness? That may sound dramatic. But stay with me. I recently saw an 82-year-old patient who presented with fatigue. His laboratory results were normal. His imaging was unremarkable. Medication list stable. On paper, everything looked fine. But when I asked a simple question, "Who do you speak to every day?" he paused. His wife had passed away. His children lived out of state. He had stopped driving. Most days, he watched television and went to bed early. He said he was fine. He was not fine. As physicians, we are trained to chase pathology. We investigate abnormal numbers. We respond to acute events. But emotional erosion does not show up as a critical value in the electronic medical record. It shows up as subtle withdrawal, fragmented sleep, irritability, cognitive slowing, and the phrase, "I do not want to be a burden." We are witnessing a demographic shift that is transforming healthcare. By the end of this decade, all baby boomers will be over 65. Nearly 1 in 4 older adults lives with a mental health condition. Men over 75 continue to have some of the highest suicide rates. Social isolation increases the risk of heart disease and stroke. These are not abstract statistics. They are multipliers of morbidity and mortality. And yet, mental health in seniors remains underdiagnosed. Why? Because older adults often do not present with textbook symptoms. Depression may appear as insomnia or somatic complaints. Anxiety may manifest as frequent medical visits or excessive health worries. Cognitive decline can overlap with mood disorders. If we wait for patients to declare that they are depressed, we will miss the majority of cases. Let me ask you something directly. When was the last time you asked an older patient who they speak with daily? Not about their medication adherence. Not about their blood pressure. But about connection. We often assume that family is present. We assume that community exists. We assume resilience. Those assumptions can be dangerous. Cognitive behavioral therapy remains one of the most evidence-supported interventions for depression and anxiety across age groups. It works in older adults. It reduces distorted thinking patterns. It improves behavioral activation. It decreases catastrophizing. Yet many physicians still hesitate to refer older patients, assuming therapy will not be effective at this stage of life. Mindfulness practices also deserve serious consideration. Structured breathing exercises, guided meditation, gentle movement practices, and gratitude reflection have demonstrated measurable impact on anxiety and stress regulation. This is not alternative medicine. It is complementary evidence-based care. But here is where I want to challenge industry best practices. We are very comfortable prescribing medication. We are less comfortable prescribing social structure. What if we treated social engagement as seriously as antihypertensive therapy? What if we developed a habit of social prescribing, intentionally connecting patients to community programs, intergenerational groups, faith communities, volunteer networks, or structured day activities? Some will say that this is outside the scope of medicine. I disagree. Loneliness predicts hospitalization. Depression doubles certain risk factors. Anxiety worsens chronic disease management. These are clinical outcomes. If a factor predicts outcomes, it belongs in our scope. There are also ethical and legal implications to consider. Failing to assess mood disorders in vulnerable older adults can expose practices to liability. Documentation of suicide risk assessment is increasingly scrutinized. Integrating behavioral health into primary care is no longer optional in many systems. It is becoming a compliance expectation. But beyond compliance, there is responsibility. One of the most difficult conversations I have had was with a family who assumed their father was simply aging normally. He had stopped engaging in hobbies. He had become withdrawn. His appetite had declined. They believed it was inevitable. It was depression. With therapy, medication, and structured social re-engagement, he improved dramatically. That outcome was not inevitable. It was preventable. I have also seen failures. I have seen patients discharged from hospitalizations for medical conditions with no behavioral follow-up. I have seen referrals delayed because transportation barriers were never addressed. I have seen hearing loss contribute to isolation that went unnoticed for years. These are not dramatic oversights. They are small gaps that accumulate. So let us talk about practical steps. Screen routinely. Not only when symptoms are obvious. Ask human questions. Who do you spend time with? What brings you joy? When did you last leave the house for something meaningful? Identify barriers. Transportation. Mobility. Hearing impairment. Technology literacy. Develop referral pathways that are frictionless. If the process requires multiple phone calls, it will fail. Follow up intentionally. Isolation is dynamic. Circumstances change. Measure what matters. Track behavioral health referrals. Monitor follow-up completion. Observe changes in emergency department utilization and medication adherence. This is not about adding complexity. It is about shifting attention. The future of senior care will likely include integrated behavioral health, predictive analytics to identify loneliness risk, reimbursement models for social prescribing, and expanded community partnerships. Artificial intelligence may assist in identifying patterns of withdrawal in electronic records. But technology will not replace relational medicine. As physicians, we have influence beyond prescriptions. We shape culture within our practices. We normalize conversations. We decide what is worth asking. Let me ask you a provocative question. If an older patient has perfect laboratory values but no meaningful human contact, are they truly well? I invite you to reflect on your own practice. Where are the blind spots? Where might subtle suffering be overlooked? If this conversation resonates with you, leave a comment. Share what you are seeing in your clinic, hospital, or community. Share your challenges. Share your solutions. And please share this episode with colleagues who care for older adults. Start the conversation in your department. Bring it to your leadership meetings. Engage with the community around you. We cannot treat mental health as secondary. We cannot treat isolation as inevitable. And we cannot afford to remain silent while our patients quietly withdraw. This is an invitation to rethink, to lead, and to build systems that see the whole person across a lifetime. If you are ready to elevate the standard of care for aging populations, join the dialogue. Step forward. Contribute your insight. Help shape the future of integrated, humane, and evidence-informed medicine. This has been another episode of Medicine Across a Lifetime. Until next time, continue practicing with clarity, courage, and compassion.